And I'd like to go ahead and introduce Dr. Strand. As most of you know, he's a professor in the School of Pharmacy and in the Department of Public Health at NDSU. He's devoted his career to chronic disease epidemiology research and the design, implementation, and evaluation of programs to prevent chronic diseases. Dr. Strand has published 80 peer-reviewed scientific publications and counting, I'm sure, given 176 presentations, received $1.9 million in research funding. And in addition to teaching epidemiology and chronic illness prevention and management in our MPH program, he is the One Program co-founder and co-PI and the senior scientist at the NDSU Center for Collaboration and Advancement in Pharmacy. And we look forward to hearing him talk about the One Program today. Thank you. Welcome, Dr. Strand.
Thank you for the introduction and for everyone's participation and attendance today. So today I'm going to consider primarily how we evaluate the population level impact of an intervention. Although I'm reporting on the One Program here in the state, and I'll tell some details about that, I'm almost as much desiring today to talk about how we evaluate the work that we do so that it can achieve the optimal impact at the population level. So first, what is the purpose of a public health intervention? So in response to a health problem, an intervention will be designed, and I know many of you on this call, I know are delivering interventions, designing and delivering interventions, so you know what this means, but just to review, and we design and implement these interventions in order to intervene in the causal pathway of an existing health problem in order to change the outcome of that health problem. Now, in public health, if anything, we are zealous. Public health professionals are not only trained, we are not only trained to perform our roles, we're also frequently very passionate about our work. And so we do so out of a firm belief of its value and importance. And so consequently, there are many public health interventions and programs that are enthusiastically supported. And at face value, they're intuitively valuable, but they may not have been subjected to evaluation. And so we may not be clear exactly on the impact they're having. So for example, community events around the theme of getting people outdoors and being physically active are very popular and go a long way toward helping get people, reminding people about the value of being active and outdoors. However, a lot of reviews have suggested they don't tend to change people's actual physical activity levels over time. So it's important for us to evaluate the work we do. Now, the interventions that we deliver are for a lot of different purposes. So I don't want to imply in any way that this is only for, say, medically measurable outcomes. Certainly, we do interventions to prevent disease in at-risk populations, to promote health and advance healthy lifestyles, to improve population health outcomes and quality of life, and also to reduce social inequities and stress and increase social solidarity. So I want to be clear that I'm thinking about this very wide, in a broad way and in an inclusive manner in terms of what types of things we need to happen at our communities. And that's not only just in biomedical measurable outcomes. So let's talk a little bit about the opioid epidemic, which is the background for today's presentation. So this is a slide that many of you have seen, which is really the unfolding of the opioid epidemic in our country. Starting in 1999 as a result of I would argue, we now know, reckless prescribing of opioids, we began to see an increase in opioid-related deaths. Initially, in the first wave, largely because of misuse of prescribed opioids. Over time, as some opioid prescribing patterns were altered, individuals were really forced to resort to heroin and other illicit drugs, which led to the second wave of the opioid epidemic, which was increased heroin use. And that ultimately led to the contaminating of heroin with synthetic drugs, such as fentanyl, which has resulted in even an increasing amount of death. And so mortality now is largely a result of fentanyl-laced heroin. Now, if you wonder, why did the opioid prescribing, direct opioid prescribing mortality sort of plateau? And by the way, it's still only plateaued. It hasn't really dropped. So it's still a major contributor. Well, because in 2016, the CDC put in place rather strict opioid prescribing guidelines. Finally, I would argue 16 years a bit late. But the result of that was in North Dakota and across the country, the volume of opioid prescribing began to decline and has continued, up until today. However, I would argue that from a population health perspective, with an addictive substance like opioids, supply side solutions are insufficient. There also has to be significant work done on the demand side, which is altering the patient encounter in such a way that their desire or seeking of those opioids is altered. The consequence of some of that decline in opioid prescribing did not result in a decline in opioid overdose deaths, unfortunately. So as you can see, we peaked out in 2016 in North Dakota. Here you should pay attention to the blue line, which is opioid-associated mortality specifically. We did begin to see a decline over the last couple of years, but in 2019, we were back to, at 38, which is about the same, and 2020 numbers even higher. And so overdose deaths have not declined in parallel with the reduction in opioid prescribing. This reminds us that opioid addiction or opioid use disorder, and I'm going to use opioid use disorder as the word addiction is passé and not the preferred term, but it's one we're familiar with, but I will revert to opioid use disorder. This study actually projects that even with a reduction in incidence or new cases of opioids by as much as 11.3% per year, we would still only see a modest decline in overdose deaths over the next several years. And the reason for this is because opioids are very addictive. And when a person develops an opioid use disorder, it frequently begins a 10-year journey of recovery and relapse. And so the ability to see a significant reduction in overdose deaths requires that we will keep our hand to the plow of safe opioid use for at least the next 10 years in order to genuinely begin to in order to both maintain a reduction in incidence of opioid use disorder, which would mean reduction in new cases developing, which would then ultimately, after about 10 years, begin to see a reduction in overdose deaths. So just beware that overdose deaths are not a very sensitive measure of the opioid crisis. They're usually a 5 to 10 year reflection of a 5 to 10 year lag in the problem. In terms of North Dakota, what are the implications here? So the prevalence of adult prescription, now bear in mind, this is prescription, not illicit. Opioid misuse is 1.5%. So in North Dakota, we would expect 7,220 adults to be misusing opioid prescriptions. And by the way, among those who are prescribed opioids, the prevalence is even higher, up to 12.5%. And then the prevalence of opioid use disorder is 0.81%. So in North Dakota, we would expect about 4,000 adults to be struggling with an opioid use disorder. And by the way, the prevalence among those who are prescribed opioids is 16.7%. Among chronic opioid users, which makes up about 40% of all patients receiving opioid prescriptions for pain, the prevalence of opioid use disorder is 8 to 12%. So this suggests that pharmacy dispensing opioids is a possible opportunity to provide support and care to these individuals in order to reduce the harm that might come later. We also found in our program that 4% of all participants have been identified as at risk for opioid use disorder. Now that includes everyone in the state of North Dakota who's a part of the program, whether they're getting a supply of oxycodone for a tooth extraction or whether they're a chronic pain patient. 4% have been identified as at risk, which is a substantial number when you consider this volume of opioids that are prescribed every year. So this brings us, this is just to set the stage for the opioid epidemic in our country and in our state and some of the history. So then what shall we do about the opioid crisis in the United States? This is an indication of a point I'd already made regarding the growth in opioid sales and the indisputable fact that reckless opioid prescribing was the starting point for the opioid epidemic. So when we started the program, we conducted a root cause analysis in order to get to the root of the opioid crisis. We discovered that nearly half of all opioid overdose deaths involve a prescription opioid. and that many of those abusing prescription opioids or even heroin had a prescription medication as their entry point. And yet many patients who have been surveyed did not perceive these medications as unsafe. So consequently, over 450,000 people in our country have died as a direct result of opioid overdose use. And in fact, for the first time in decades, life expectancy in the US declined as a result of substance use disorder associated early mortality. In fact, resulting in US persons losing an average of 153 days of life. So it's hard to overstate the impact this has had on our society because people are living in pain. So one of the causes of the opioid epidemic then has been prescription opioids. So considering we feel like we got to one of the roots of the crisis, we asked the question, could we possibly go back to the root and use it as a part of the solution? So this is a pathway that we considered from our root cause analysis. And if you look at the end of this sequence, you'll notice it's overdose death. Overdose deaths are, in our state, 38 people maybe, but there's 8,000 persons in our state whose life is compromised and their quality of life is compromised because of misuse of opioids. So although the 38 deaths in our state are what capture our attention, and obviously it's a tragedy for the individuals and the families and loved ones affected, we also, from a public health perspective, want to consider the 8,000 persons in our state who are living each day with pain that's being managed in different ways and resulting in harm or misuse. So let's move back up the pathway then. So an overdose death will result from an individual who has, well, let's go back to the beginning. I'll just go in sequence. It's maybe more logical. So the starting point of an opioid use disorder is a life circumstance. Individuals with mental health disorders, depression and anxiety are known from our research to have a much higher occurrence of opioid use disorder. A surgical encounter introduces naive patients to a medication, which then hits the mu alpha receptors in the brain and causes this instantaneous euphoric experience that for some individuals who are predisposed can be very appealing and be the starting point for misuse. Chronic pain management, incarceration contributes to drug misuse. Trauma and other substance uses can be the starting point in a life circumstance that results to being exposed to opioids, either prescribed or illicit. Upon exposure, we know that a portion of those individuals are going to have that positive from their own perspective experience that results in their experimenting with opioids in an unsafe or an illegal way. Then that results in misuse of opioids, buying them from others, stealing them from others, multiple doctor shopping and pharmacy shopping in order to satisfy that need. And in some cases, that then results in an opioid use disorder. The opioid use disorder then will result in significant harm associated with that, such as an overdose, work and life disruptions, health problems, an exacerbation of mental health disorders, and then occasionally an overdose death. So we asked ourselves the question, and remember back that slide, that it's going to take 10 years if we could reduce the incidence of new opioid use disorder cases by 11.5% per year, which would be a fantastic effort, we would still only see a reduction in overdose deaths of just a minuscule amount in the ensuing 5 years. So we feel as if our greatest contribution could be to the reduction in an incidence by keeping people from starting down the pathway of an opioid use disorder, meaning when they are first exposed to opioids, providing support and services appropriately to prevent misuse. So this gets us to the issue of prevention, which is a heart and soul element of public health. Pharmacy and medicine, I would say almost prior to the one program, have been using what I would consider a reactive rather than a preventive approach. And I also use the term a supply side approach. So the prescription drug monitoring program is a program where any patient picking up an opioid is evaluated for whether they have looked at if they've seen multiple providers or multiple pharmacies, and that would indicate that they're drug shopping, and then they would be forbidden to fill that prescription. So that's a supply side restriction. Then that results in refusal to fill. Additionally, medication take-back programs where we encourage them to take them out of their homes is really a supply side reduction. But we consider that upstream prevention is what's needed most. So let's think about our basic principles of public health for a moment. So using the concepts of primary, secondary, and tertiary prevention, a lot of work has happened at the tertiary prevention level where we manage the impact of advanced disease to minimize, in this case, overdose and overdose deaths. So we would like to move upstream and be able to focus on primary prevention where the person doesn't have disease, but they're at elevated risk, prior even to the onset of symptoms or clinical presentation. And so the primary level would involve the prevention of disease before it occurs. And that's where we consider our screening tool to be a possible opportunity for identifying individuals when they pick up those prescriptions in their pharmacy. When you think about the services that are available for the 3 levels of prevention regarding opioid use, you'll notice immediately that the vast majority of the services are geared toward tertiary prevention. That is, patients with advanced opioid use disorder. So if you start at the bottom of the line, cessation or treatment, medication-assisted therapy, allowing them to continue to remain on a low dose of the opioid to manage their substance use disorder. The use of naloxone, which is to reverse overdoses to prevent death. The prescription drug monitoring program. So these are designed for individuals who already are at an advanced stage. But we were concerned about providing services that could be implemented at the primary level, which meant for us initially screening. This brought us into familiarity with the opioid risk tool that I'll talk more about in a minute. It also allowed us to design an algorithm that identified red flags for patients who are at risk of an accidental overdose, and then from that to be able to deliver patient counseling to them. So I'll offer a bit more explanation of these things here as we move along. So as we think about the possibilities, so I've tried to make a case that primary prevention is an opportunity with opioid use disorder because of the nature of the chronicity of the disease and the opportunity to identify individuals at elevated risk by use of the opioid risk tool. These are some of the requirements that we felt like our proposal met. So for an opioid use disorder or an accidental overdose situation has to have a detectable preclinical phase when we can screen. That is, there has to be something about the patient that can be identified prior to them having opioid use disorder clinical symptoms and to be identified. And we believe that the screening tool, the opioid risk tool, is ideal for that purpose. The primary prevention approach also requires access to a population with elevated prevalence or risk. You wouldn't want to do opioid use disorder screening in a shopping mall or in a public high school or at a university campus. In other words, you want to focus on communities where you know that there's going to be an elevated prevalence or risk. And so what better place than in a pharmacy among patients who are picking up opioid prescriptions? And then finally, primary prevention requires that you're able to provide services in that setting where screening occurs so that you don't lose individuals, that there's no disconnect. And we know that opioid management issues across the country suffer from lots of links in the chain of opioid care exist, but they're oftentimes not connected well, so people fall through the cracks. Now, what is the pharmacist's role in this? The pharmacist's expertise and training aligns with patient and provider education, which is required because of the OBRI laws. They're able to identify potentially harmful prescriptions or drug diversion, and they're also able to screen patients. And in fact, pharmacists are now doing screening for lots of health concerns, such as hepatitis C and other conditions. So this is aligning with pharmacists' work, and therefore they're uniquely positioned to have a significant impact in turning the tide of the opioid crisis. So I hope I've made a case for the role of pharmacy and prescription opioids in the opioid crisis, both in its origins and in opportunities for solution. And this leads to the question, what is the ONE program, the Opioid and Naloxone Education program? We started out with the name ONE-RX, and many of you are familiar with that, but we ended up changing the name to a simpler. We wanted to keep it simpler. So what is the ONE program? The purpose of the ONE program is to optimally impact population health with regard to safe opioid use and prevention of opioid misuse and accidental overdose. So the program was designed to prevent misuse and overdose by utilizing community pharmacists to screen all patients receiving an opioid for their risk, and then to deliver services to them in that same setting in order to optimize benefit and patient harm. And so this is what I'd like to talk more about today. And here you see an example of a patient picking up an opioid prescription and the pharmacist then going through the program with them. The design of the program was built on the 4 core principles of the CAP Center. It was mentioned that I'm a senior scientist in the CAP Center, and we have a model that we use for the design of interventions. And I'm not going to go over this in detail, but just to point out that we consider program implementation to designing the program and the implementation to be a cyclical process that happens all the way through. After that, education and training is provided so that those who will deliver the intervention are qualified and feel comfortable that they can do it. Coaching and support is provided to help those individuals persist in it, and then capturing data and outcomes so that we can evaluate it after the fact. So now a little bit more about the details of the one program. So this is an example of a patient entering and filling out their forms on the tablets that we provided to participating pharmacies. But the algorithm on the top shows you the pathway. So a patient with an opioid prescription, all patients with an opioid prescription come into the pharmacy and deliver that to the pharmacist. They're then given our screening tools, which screen for 2 things. First is the use of the opioid risk tool to screen for opioid misuse risk, and then also to screen for the risk of an accidental overdose. Based on the results of those 2 screening tools, the pharmacist is then able to decide which of a basket of interventions are appropriate for those patients. That would include things like recommending a partial fill, promoting medication take back, providing naloxone for those who are at risk of an overdose, introducing community support services, making referrals as necessary, and then also consulting with the individual about opioid misuse issues. So first, the evaluation of the risk of opioid misuse. This is the opioid risk tool, and this is not for evaluating that a person is currently misusing opioids. It's rather asking questions that have been shown through statistical testing to be highly predictive of opioid misuse. So that includes a family history of substance abuse, personal history of substance abuse, being between ages 16 and 45, having a history of pre-adolescent sexual abuse, and then also having a history of psychological disease. Each of these is then given a different point value, and then from this is given a score, and a score of 8 or higher would be considered to be high risk for an opioid misuse condition. It's not diagnostic, but it's known to be highly predictive of individuals either presently or in the future facing that risk. The second, that's the risk of opioid misuse. Secondly, we also want to screen for a risk of accidental overdose. So on the top, you see the ORT tool, and then the bottom half of the intake form looks at the risk of accidental overdose. So that includes comorbidities. So if an individual is depressed, has sleep apnea, that's a respiratory disorder, and that can be associated with depressed breathing, which is what persons die of if they're in an excess of opioid intake. So those are comorbidities. And then the bottom would be concomitant medications, or those medications like benzodiazepines or sleep aids, which in association with an opioid can decrease one's respiration to the point of an accidental overdose. So the 2 tools are used. And then the pharmacist follows this triage tool. So you'll see, this is another way of depicting it. So start in the bottom flow chart there from the left. So they bring in their prescription, they're administered the ORT. If the score is, that should say 8, not 4. If the ORT score is higher than 8, they're then looked at for red flags of PDMP misuse and also the pharmacist's professional judgment. That might result in, to the left, calling their provider to ask whether this prescription should be reconsidered. It also includes discussing with the patient the risk, or assessing the patient for the risk of accidental overdose. That would then lead to 3 services delivered. First, prescribing naloxone, that's the N. C would be counseling the patient on substance use disorder, that's the C. And then P, counseling them on pearls for safe opioid use, that's the P. On the other hand, if their ORT score or their risk of substance use disorder is low, they would still go on to do red flags for like accidental overdose. And then that would result not in naloxone, that would result in naloxone prescribing and counseling on safe opioid use, but less attention paid to counseling on substance use disorder because they were not screened as at risk for that. So this is the triage tool that's being used. The result of the triage tool then, coming back to the algorithm, results in any of those services being delivered based on their score. And the images on the bottom are to depict that. So the blue box is the MedSafe box, which you'll see in pharmacies all across the state. And once we began this program, they were overflowing with returned medications. You see a Narcan nasal spray, that's for reversing overdoses. And we've increased the dispensing of Narcan across the state to 10-fold higher than national averages. The next two resources talk about addiction and the safe use of opioids. So those would be some opportunities to consult the patient. And then finally, community support services are introduced to the patients. So what are the results of this work? Here's some preliminary results. The average age of our, this is through like November of last fall. So this is a couple of months behind. We have screened 8,217 patients in the state. Now remember, there was, I predict 8,000 persons struggling with opioid use disorder in the state in association with prescription opioids. And those numbers are not a match apples to apples, but they suggest something in the ballpark. So then the average age, 48.8 years, gender is a little bit more female. History of depression, 20%, and anxiety, 20%. That matches with the literature. And then taking a muscle relaxer or a sleep aid is associated with 30% of these patients. Those who are at risk for an opioid use disorder is 4%, and then at risk for an accidental overdose, 18%. So this is a large number of individuals receiving services. And then, as I had mentioned previously, the individuals who are chronic opioid users represent 31.7% of all patients. And as you remember, you may recall, 16.7% of patients who are chronic users are at risk of an opioid use disorder. So these are the interventions that I showed on the diagram earlier in some detail. I won't go into a lot of detail. I think they're pretty self-evident, but medication take back, partial fills, discussing those services, naloxone, and then the others that I already referred to. And how were those delivered? So these are the interventions provided. 85% of patients were introduced to medication take back, which explains why those MedSafe boxes were overflowing with returned meds. 4% filled a partial fill of the opioid, and we wish that were higher, but that's been uptake has been lower. I would also point out at the bottom, only 2.8% of patients had contact where the pharmacist contacted their provider or their prescriber to talk about it. I think there's a lot of opportunity there to increase communication with providers in a way that's in the best interests of the patients. Community support services or referral, 12.3%, prescribing naloxone, 24%, and then dispensing, 9%. So you'll see these pharmacists have been very active. And you say, how do they have time to do this in a busy pharmacy? This takes on average 4.8 minutes to complete per patient. And so that's how. So this leads me to another part of this talk, which is the evaluation piece. So this all sounds fine and good, but how do we know the level of impact that our intervention is having on the population? We see the benefit to individual patients, but what about on the population level? When we first started this program, we literally within months of the program, a pharmacist from Bismarck called us and said, yesterday, a patient came screaming into our parking lot, driving, came running into the pharmacy and said, my friend has overdosed. Can you help me? All the pharmacists in that pharmacy had been trained in naloxone administration. And also they had finally begun stocking naloxone because of participation in the ONE program. The young pharmacist ran out to the car, administered the naloxone, and saved that person's life. Obviously, we were very excited by this news and felt great satisfaction. But again, from our public health perspective, we continued to ask ourselves, But how big is the impact on our entire population, given the population level burden that the opioid crisis has presented? And that's what I'd like to introduce now. So with that, I'd like to introduce what's called the REAIM model. REAIM is an acronym for reach, efficacy or effectiveness, adoption, implementation, and maintenance. Now, this is a personal story because Russell Glasgow was a professor in the doctoral program that I studied at the University of Colorado in 2000. And in 1999, he had just published the seminal work launching the REAIM model, which was designed to help with planning and evaluation of programs to determine possible or actual impact they had on the population level. That seminal paper has now had 2,800 citations. And one of my classmates actually did her dissertation with Russ and was a part of that. So when I was doing my PhD, Russell and his REAIM model were a big part of our conversation. So those of you who are students, don't underestimate involvement with your faculty can be really critical, important, and have future impact that you never imagined. And I'd like to point out that our one program was actually featured on their website, and here's a link for that after the fact, because they considered our application of the REAIM model to be exemplary. So what about the REAIM model? So this is a framework to address the issue that the translation of scientific advance into practice is often weak and slow. It's inequitable. We demonstrate that it can work in a controlled setting, but then we struggle to figure out how to upscale that. And so the unique features of the REAIM model are to look at the issues and dimensions in the design, dissemination, and implementation that can either facilitate or impede success on a population level. And I've become a big fan of the REAIM model over time. These are some definitions of each of the domains. So reach would be how much of the target population are reached. Efficacy is how effective is the intervention. Adoption would be how many sites who could participate choose to adopt the program. Implementation is of those sites who choose to adopt it, how many of them implement it consistently with high fidelity. And then maintenance is how many of those sites continue doing the intervention at least 6 months or 12 months or whatever the definition of maintenance is that you choose to use. So the first two criteria are at the individual level, and then the last three are more at the site or location level. So across the top are the 5 domains of the REAIM model, and then on the bottom is how we've defined them in the one program. I'll skip the general definition. That's just what I kind of went over with you on the previous slide. But in our program, so the percentage of reaches of all patients receiving opioid prescriptions, how many of them complete the screening? In some tools, that would be called penetration. Efficacy is the number of patients with an ORT score of greater than or equal to 8 who receive any of the 6 critical interventions. Adoption is the number of pharmacies in the state who enroll in the program. Implementation is the number of pharmacies who adopt the program who actually go on to complete at least one screening. That is, they get started. And then finally, maintenance is pharmacies who have implemented the program and who are still screening 3 months after adoption. So here's some of the values in our evaluation. So at the bottom, you'll see our denominator. So one of the challenges with this REAIM model is you need to have denominator information. So we did a test at 10 locations in order to determine reach. We looked at all of our values at that time. And so our program target was to reach 90% of patients. We thought these pharmacists know they've been trained, the patients are all coming in. And after our evaluation, we determined that only 16.9% of eligible patients have completed the screening. I'll talk more about that later. Efficacy, we thought 60%. So we believe that of those who were screened, 60% would receive services appropriately. And in fact, it was 78.3%. It was much higher. And this gave us a lot of confidence in the validity and the value of the tools that we had used and designed. Adoption is the number of pharmacies who who enroll. So of the 149 community pharmacies in North Dakota, 67 adopted the one program. Our target was 25%, and we were surprised to find 45% of them adopting, and we were thrilled. However, implementation, that is those who adopt, who actually go on to complete at least 5 screenings, Our target was 80%. We thought if they adopt it, surely they'll carry on, actually start it. It turns out only 44.8% of those who adopted it actually got started. So there was a hang up there. So this kind of evaluation allows you to identify, if we want to have optimal population impact, where are the shortcomings? And now we've identified two. One, to increase the reach, that is the eligible patients who come in getting screened. Another is those who adopt it to actually get started. And that's where, back to the 4 core principles of the CAP Center, coaching and support of those pharmacies is so important. So lots of site visits and phone calls in order to increase that implementation. And we got lots of confirmation of that because our maintenance was 80%. That is, of those pharmacies who implemented the program, the 30 who implemented, 24 of them were still doing it 3 months later. So they could maintain it. So they saw its value. It wasn't too disruptive to their workflow. It increased patient interactions. And so it could be maintained. So this gave us a lot of confidence about how we could improve the quality of the program. And this is what that looks like, graphically. So you'll see the target is on the left and the actual is on the right. And, I'm a firm believer in the scientific method. In 1605, Francis Bacon, who's considered to be the father of the scientific method, had this to say: if we begin with certainties, we will end with doubts. But if we begin with doubts, we will end with certainties. And I think sometimes in our interventions, we begin with a lot of certainty that because it's an important intervention, or because it's an evidence-based intervention, or because we have a lot of concern about it, well, then certainly it'll be effective. But I think we want to hold out on Francis Bacon's basic principle of starting with doubt, and maybe in some cases assuming the barriers and taking them as a given and going into it. The challenge is we never know what the actual barriers are until we do the evaluation. And so in this case, you'll see the reach and the implementation are the areas where our expectation was the most divergent from the reality. That was not what we expected. So what you'll see is on the left is our expectation, and then on the right is the reality. It's always humbling, but that's the scientific method. So then let's talk about each of these domains just a little bit to unpack how we did that. So the reach of the one program. So the patients who received an opioid prescription who completed the screening. So we used 10 pharmacies to use a kind of surveillance method. There were 3,839 prescriptions filled, with representing 2,187 patients. In other words, there were a lot of refills. So then the reach value is the 370 patients who were screened among those 2,187 distinct patients. That's where the 16.9% came from. Now, as you all might guess, it wasn't as if it was 16.9% across all pharmacies. It went from 3% in one pharmacy to a high of 53% in another pharmacy. Well, this evaluation allows us to say, what are those pharmacists in the 53% doing? Because they're getting more than half of their patients. And how can we identify them to be a part of our coaching calls in order to help those other pharmacies increase their reach in their patients. Some of the barriers we identified when we did that were sometimes the family picks up their prescription, so then you can't do the screening with that person. They might argue they're too busy. Some are concerned that the conversation is too difficult, so they don't even want to do the screening. They maybe know this is a chronic user and they know it's going to be a hard conversation. And yet we have demonstrated that actually these tools make that for an easier conversation. And then finally, we found that patient familiarity, although it can increase quality of care, sometimes patient familiarity can result in too many assumptions about, the kind of the best case scenario. Whereas, and therefore choosing to say, well, I know that person, I've had them in my care for a long time, and I know they're okay. And then sometimes that can mean missing out on the opportunity to provide care for them because of familiarity. So that's R. E, efficacy. The efficacy of the one program is demonstrated by those with an ORT, that is high risk of opioid misuse of 8, having one or more of the 6 critical interventions that I had already referred to previously. And so here are the results of that finding. So of those, so first look at the column. So the individuals identified as at risk of a high opioid misuse would be 1,653 individuals, and then 6,564 were not at risk. And then of those who are at risk, 78.3% received one or more of those critical interventions. So that's where we evaluated the efficacy, 1,294 divided by 1,653. Now, on the other hand, those who were considered not at risk also got the benefit, but we didn't consider that 31.7% as a waste of time because it didn't take a lot of time. And even though they weren't identified as at risk based on high opioid misuse risk profile, they're still encountering a medication that has lots of complexity, and therefore those services are still considered beneficial. Some of the program implementation elements that we used, one was to use some marketing and use of social media to get the word out. We developed a one program website, which is a link to the North Dakota Board of Pharmacy and has attracted a lot of attention from around the country. We implemented a beta test site first so that we could evaluate efficacy and impact on workflow and pharmacists' acceptability of it. That allowed us to also then develop a reimbursement structure using the SPURT model, that is screening, brief intervention, and referral to treatment, that's often been used with regard to alcohol misuse, which allowed us to then create a program that reimburses pharmacists $20 per screening. And here you'll see on the right side a pharmacy across the state being recognized for having met our gold level performance targets. So that was another element, was we had bronze, silver, and gold recognition for pharmacies based on their performance. And that was a fun and I think a beneficial, friendly competition that promoted the uptake of the program. Additionally, as I mentioned in the 4 core principles, education and training is extremely important. Pharmacists are well-educated and well-trained persons, but they also at times fall into the ruts, as we all do in our work, of doing things the same way they've always done it. So if you're introducing a new program, you need to provide training and support to increase self-efficacy in the implementation of it. So we provided trainings. We did 3 live trainings across the state, and this is one of them. And then we also provided on-demand training, and it's still available. And we've trained probably 250 pharmacists and technicians in this program now over the last 3 years. So that's been very satisfying and an important part of the program. So re-aim, now we're up to the A, adoption of the one program. So the 67 North Dakota pharmacies enrolled out of 149, so that's a 45% adoption. And here you can see they're pretty well scattered around the state, but bear in mind, 44.8% of these actually are implementing. So it might be a little misleading that way, but I did want to present at least the adoption. And some of those actually are, even a year or 2 later, are finally kicking it in gear. Maybe they get some students to come through and they invite the students to help get the program rolling. So it continues to increase. REAI implementation. So this would be those who adopted it. They actually continue to do screenings up to 3 months later. So that's 30 out of 67. That's that 44.8 or 45%. Some of the issues here was that the pharmacist in charge needed to really buy in, so they supported it. We had onboarding, which included a welcome packet and a Samsung tablet. You'll see the image here. We provided virtual coaching calls to pharmacies around the state, and here's our 3 of our team members providing that support. A monthly newsletter, and then sharing updates to build energy for the program. And then finally, REAIM, the maintenance. So maintenance we defined as still doing the program 3 months later, still screening on a monthly basis 3 months later. And so of the 30 who actually implemented, 24% accomplished that. So that's 80%. So that shows once they get over the hump and get started, they keep going with it. And this was through a lot of mechanisms. I just referred to some of them on the previous slide. But it also included things like going to their location and talking to them. Here I went out to give this pharmacy their silver level certificate. And look at the smiles on their faces. We just all need to be valued. We need to be recognized. They don't do the work for that piece of paper, but just acknowledging people's hard work, it goes a long way. And I do want to take this chance to thank all the pharmacists across the state who participate in the program, and even more, the thousands of patients receiving opioids who are desiring to improve their quality of life and manage that opioid use safely. We did have disruption during COVID, as a lot of programs did. So trying to be patient during that time was another important element. Now, I want to summarize the REA model using the outline of the map of North Dakota. Now, bear in mind, this map is not meant to show where in North Dakota. It's not like Wahpeton is like, the far, southeast corner is where we're working. So bear in mind, I'm using the shape just to suggest our state. But in fact, I'm using it more for mathematical purposes to show the proportions covered. So if every element of the REA model was at 100%, so that is, we reached every patient, all of them had 100% efficacy, all locations adopted it, all who adopted it implemented it, and all who implemented it carried it out for at least 3 months, then this whole state would be covered, and that would be 100% population impact. We didn't hit the 100%, and no program does. And so bear in mind, even I would say anything 5% population level impact is considered success. So don't be startled that none of these variables are at 100%. So let's look at each of them. So first, adoption. I thought that was a place to begin. So the red line suggests that 45% of pharmacies adopted the program. So that means 55% of patients in other pharmacies are not standing to benefit from the program. So it has nothing to do with the patient. It's simply that the pharmacy didn't adopt the program. 45% adoption. Implementation, 44.8%. So that's the green line. So now we got basically the lower right quarter of the state outline shows that this is now, in other words, 44.8% of the 45% leaves that lower right quarter. So about a quarter of the pharmacies in the state implemented the program. So that means 75% of the patients in the state have no opportunity to participate because their pharmacy did not implement the program. The maintenance is then 80%, so then that draws another line down. So now we're talking about from the green line and below and the blue line to the right, now we're down to that portion is our population impact. But then the reach, only 16.9% of the patients coming into the pharmacy with an opioid prescription are being delivered the intervention. So then that drops that purple line down. So now we're just left with that smaller lower right corner. And then fortunately, the efficacy is 78.3%. So if we can get the patient screening done, 78.3% of them are going to get the appropriate benefit. So then that's the hatched area on the right. So the ultimate population impact of the one program in North Dakota is depicted by the hashed box area in the lower right. Now, I'm not doing this to beat ourselves up and say, well, why didn't we cover the whole state? That's science, that's the challenge of implementing programs. But I do want to just point out that this kind of rigorous evaluation allows us to both be honest about the impact, but it also gives us opportunities to see where we can improve the program. And I would say right now, the biggest opportunities for improvement are to increase implementation among the adopters. So moving that green line up and then increasing the reach among the patients coming in, moving that purple line up. So if the green line and the purple line each could be moved up to even 80%, well, then you could feature how that would increase that hash box area 5-fold or more, and thereby increase the patients who have access to the program. This leads me to close to the end here, a slide to just show a public health model, and I think I have to do this just because of my desire to increase implementation science and program implementation. So up the staircase, so a lot of us do research and more of us even do practice. So in my mind, public health is a practice-based research endeavor, but we need to do both. And today I'm trying to make a case for adding more research rigor to the implementation of our practice. So the first step in this is to identify the problem and to conduct surveillance. So how big is the problem? Where is the problem? And I started today's presentation with a look at our own state and our own country, the history and the relevance of the opioid epidemic. Secondly, you then identify the risks and or protective factors to look for opportunities to change the trajectory of that problem. So what population is at risk? What factors are contributing to it? How can we lower the risk? So you can see now why this is, although certainly research, it's also research during the time of actually doing practice. So that's where the step case is moving us as we move up closer to practice and further away from just theoretical research. The third step is to develop, implement, and evaluate those interventions. So does an evidence-based intervention exist that you can use? Can it be implemented? That is it feasible? And then today I've tried to introduce the 4 core principles that I think are essential to ensure a quality intervention that can be implemented, where you support the implementers and where you then evaluate the results over time. So now it's even more practice-based, because how can we evaluate it without actually implementing it? So it's the combination of research and practice. And then finally is the translation and dissemination or upscaling. So that's translation research to upscale it and rigorous evaluation of the data and outcomes in order to know how to improve it. So what's next for the ONE program? So a couple of things to share. Here's some of the expansion opportunities. So we want to provide rigorous guidelines for providers. We've been working with pharmacy, but we would like to see the more attention paid at the prescribing level. We've expanded the ONE program to 2 states, Idaho and West Virginia. We were thrilled to have a chance to deliver this in really the epicenter of the opioid crisis in America there in West Virginia. And the state of West Virginia is thrilled to be implementing it. We've expanded the program to include home health nurses doing the screening with the patients that they're caring for in order to ensure safe opioid use. We'd like to see more medication-assisted therapy managed through community pharmacists, and then screening for those on medication-assisted therapy so that the medication-assisted therapy doesn't become its own source of exacerbation of substance use disorders. We'd like to expand into tribal communities. There's great work being done through the SOAR opioid response grants at Spirit Lake and at the MHA nations. And there's opportunities, I hope, for collaboration there. And we've also given more consideration to some focus on campuses and students where that primary prevention could be implemented. Finally, some of the research questions that we have that we're trying to tackle over the next year or two. We'd like to compare the health outcomes of patients who receive and who do not receive ONE program services. We haven't been able to do that kind of a cohort study. We'd like to be able to determine characteristics of pharmacists exhibiting communication avoidance with their patients. In other words, what is it about the certain pharmacists who are maybe more reluctant to do the screening with patients because of uncertainty about violating the respect or trust of the patient or come across as insulting the patient. We'd like to also consider keys to maintenance of the ONE program, how it can be folded into other sustainable programs. And then, as you could imagine, mechanisms to increase the reach, as I described. And then finally, some characteristics of pharmacies ready to begin the ONE program. So what is it about only 44.8% of those who had the desire to do the program, they adopted it, but then they didn't implement it. And we've designed an organizational readiness for change assessment where hopefully we can help a pharmacy maybe be more rigorous in deciding, am I ready to make this change? Do I want to implement this program? And that's an area, I think, for consideration. So with that, I'd like to acknowledge the team, the ONE program team. We've been together now for 4 years. Myself and Heidi Uckel, Amy Wermeyer, Elizabeth Skoy, Jamie Steeg, Oliver Frenzel, and then the 2 students in the front, but there's a lot of students that have worked with the program over the years, as well as the funders of the program, primarily the Department of Health, Human Services in North Dakota, and then some other foundations, and certainly the Board of Pharmacy. Thank you for your attention and your interest in talking about both how to improve opioid safety in North Dakota, but also from a research perspective, how to evaluate population impact of our interventions. Thank you.
I think we can all give Dr. Strand a hand. That was extremely informative presentation, and really appreciate the opportunity you took to reinforce public health principles and primary prevention. I invite anyone who has questions now to either unmute and ask their question directly or to put their question in the comments. Our first question was actually answered in your presentation. Tia had been wondering about tracking the compliance rate of pharmacists using the program, screening tools and interventions, and you did address that. Faith asks, does the reach analysis take into consideration the guidance that chronic opioid patients don't necessarily need to be screened every time, but instead periodically?
Absolutely. I didn't mention that, but yeah, the guidelines are every 6 months. So yeah, chronic patients, it did take that into consideration. Good catch, Faye. Thank you.
While we're waiting for others to speak up, I will ask, I was very interested in the screening tool for risk of opioid misuse. Is that a tool that you created and validated?
No, so the opioid risk tool was created by Jones and Compton in Nevada, I believe. So the tool was originally designed for use in a pain clinic. And so it was validated against patients who are being managed within a pain clinic. So they would obviously be more severe or higher risk than average patients picking up an opioid in a prescription in a pharmacy. So yeah, it was validated in that setting, and we have since worked to further validate the tool for use in community pharmacy.
Okay, that's what I was wondering was you know, whether the tool's being validated in this other context, and curious if there were other elements that you've discussed maybe wanting to include or adjustments that you would make to the tool potentially.
So about a year ago, a research team actually revalidated the tool, including taking out the question pre-adolescent sexual abuse among girls. You may have noticed that there's no score for boys if that experience was to happen. So they basically thought it's a pretty intrusive question, and if it's going to be used in a community setting, is it something that could be very off-putting? We have not found patients to refuse to answer it or be uncomfortable with it to a great extent. But actually what the revalidation exercise demonstrated is removing that question didn't change the results. So there has been consideration to taking that question out because of the sensitive nature of it. As far as other areas that we would consider, the depression and anxiety is such a strong comorbidity with substance use disorders, and they are scored in the tool, but we feel like that's a significant factor that should almost be a given, that persons being managed for depression or anxiety should be given, even preferential consideration because the association is so strong, sadly.
Right. Dr. Carson, you have your hand raised.
Hi, Mark. Great presentation. You probably said this, and I may have missed it. Sort of two questions on this. The overall sensitivity of the screening tool, sensitivity, specificity, if that is out there. And second is I have this vague recollection of, going to a lecture where, hearing about the risk factors and propensity for opioid addiction of a study that was done on Vietnam veterans that had battle injuries and received, pretty much universally morphine in the field, kept opioids going when they were hospitalized. And then they subsequently looked at, addiction after that because they were so generously used as a means of controlling pain for those veterans and patients. And it was a small percentage that went on to have trouble with addiction. And it was predicted by, if I'm remembering right, you could look at changes on functional MRI, including in other family members, particularly the father. And I'm just wondering if there are biologic markers that you know of that are predictors of risk. I know that would not be practical in an immediate screening tool, but I was just curious. And then again, the sensitivity about the existing screening tool you're using.
Yeah, I'm not familiar with biological markers or, imaging opportunities to look for those individuals. However, the genetic or the inherited predisposition is very strong. And that's why the ORT tool includes a family history of those misuses. So, I think that would be in the same camp, though, as strong evidence that all substance use disorders are not all directly inherited, but there's a strong familial inheritance factor there. So yeah, that's a good consideration. And part of the reason that the ORT considers family history of those substance use disorders like prescription medication misuse, alcoholism, or other factors. As to the validity of the tool, so the ORT was been demonstrated to be about 78% sensitive. So you're missing true positives, but higher specificity, so maybe 85 to 90%. So if a person doesn't have, then they're less likely to be missed. So it's imperfect for sure, but it's as we've seen it, it's certainly not diagnostic, and it's designed to increase a conversation that should have been happening for the last 30 years. But yet, because of the complexity of the patients and the sensitivity of what it means to have an opioid or a substance use disorder, it's often been avoided. And so the tool has proven quite useful in our hands. And we have a paper that's just under review right now called The Utility of the ORT, where we address some of those issues. So we feel like we're making a contribution, but it's an imperfect tool, but we consider it an effective tool.
If I could make one other follow-up question. This is just something, from personal curiosity. My little N of 2 between my wife and I both getting prescribed opioids after, minor surgical procedures. Mine was probably 20 years ago. My wife's maybe about 10 years ago. And my taking them after this surgical procedure, I experienced like significant euphoria. I was like, whoa, these are like, I gotta watch out. This is like something. And my wife had significant dysphoria, and just really didn't want them at all. And I'm kind of curious if that is a predictor, like, I would assume it's something, but like you get pain relief, but what about the euphoria or lack of it being a predictor and having conversations around that?
Mm-hmm. I haven't seen research that evaluates that kind of subjective experience or maybe clinical presentation of opioid naive patients, but I think it's an interesting, consideration. I would suggest that there would be biological plausibility that is a suggestion of a person whose brain neurology and that initial encounter is more positive and is then more inclined to want to seek that later. There's no question that a lot of people find opioids really uncomfortable and are then less likely to even want to use them for pain that they received them for, much less pursue them further. But there's a significant proportion of society of persons for whom that experience is euphoric, is satisfying. And as we know with opioids, the neurology of it, there's no ceiling on the benefit, which is why they result in death, because the more you take, the better you feel until you can't breathe. And so it's just such a sad experience, but I think that might be shown to have some association. And in fact, with that, I would want to take the opportunity to just talk for a moment about the experience. In history, individuals struggling with substance use disorders have frequently been considered to be undisciplined or irresponsible or seeking that lifestyle. But nobody wants to have to live life dependent upon medications that, while providing some euphoria and short-term relief from pain, whether it's physical or psychological, no one wants to see their life, their loved ones, their family, their work destroyed by that. And through the course of our work, we have grown to really feel the need to reestablish a professional posture of empathy toward all patients, and to recognize that this is not something that somebody wants to live with, and that if we can do anything to treat them with respect, help them to avoid going into worsening use of the opioids, and thereby be able to enjoy the highest quality of life, then we consider our work really worthwhile. And so I did want to say that in part to make sure that my concern for the persons involved and the nature of these medications and illicit versions of it, that we take that into account, because there's still a need in our society to change a narrative in order to pursue programs with empathy and respect for the nature of the disease and for the dignity of the person. So I know everyone on this call here would share that, and I know I'm speaking to the choir, but I do want to reiterate that and encourage all of us to do our part to try and continue to that end in the areas that we're able. Any other questions? Yeah, happy to. I didn't mean to end it there. but I'm
No,
happy to
thank
take
you
more
for that
questions.
additional reminder. I really appreciate that. Sarah has a question. Has cost been a barrier to naloxone distribution? Also, does North Dakota have a prescriber pharmacist practice agreement in the state? And if yes, was setting up the practice agreement a challenge?
Now, is this in the chat so I can see it because it's a multi-level?
Yes, it
Okay,
is.
the last, okay, I see it. Yeah, thank you, Sarah. Nice to see you, Sarah. Thank you. Has cost been a barrier? No, the state is providing naloxone to local public health, and then local public health providing it as needed to pharmacies, so they can be provided free of charge in North Dakota. And this has allowed for a fantastic collaboration, a heretofore never seen depth of collaboration between local public health and pharmacy, which set the stage for during COVID. It was, those relationships were all, many of them were there. So really want to commend that. Does North Dakota have a prescriber pharmacist practice agreement? North Dakota pharmacists are licensed to prescribe and dispense naloxone. If it's in reference to naloxone. So yes, there's not a practice agreement issue. It's actually authority for the pharmacist to prescribe and dispense naloxone. I hope I answered your questions. Now, I don't know if you're talking about practice agreement regarding managing of MAT or whatnot, but that's a different issue. Yeah.
While others are thinking of questions, Sarah says, thanks. I did have another one. Wondering, as you're rolling out this work in other states, if the particular laws that North Dakota has around pharmacy ownership, do you think that changes the dynamic, makes it easier or harder in North Dakota, easier or harder in other states?
Good observation, and maybe not everyone on the call is aware that North Dakota is one of the few states in the country who requires that all pharmacies have 51% ownership of a North Dakota licensed pharmacist, which basically is why you don't see Walgreens in North Dakota. You see one CVS in North Dakota because it was grandfathered in for other reasons, but you don't see corporate pharmacy in North Dakota. So yes, that does create, but it creates a challenge on two levels. On the one hand, it does allow for a given pharmacy, the pharmacist in charge or the owner, to, in a sense, do what they want to do. So those who want to uptake this program can do that regardless of what headquarters in Indianapolis might say about that. So yes, that is an advantage. And in fact, when Idaho started the program, they've started the program with independent pharmacies, partly for that reason. On the other hand, we believe that the critical ingredients, the various elements that are essential, we believe should be incorporated into all corporate pharmacies. So if a corporate pharmacy was to make our program the standard of practice, then we wouldn't have to have coaching calls all around the state. It would be required of all the pharmacies under their banner. So it has both strengths and weaknesses. Until now, corporate entities have been less enthusiastic. We've talked with them. However, I do want to point out, Thrifty White is kind of a quasi-corporate, quasi-independent ownership model, or of a franchise model, you might say. And Thrifty White has been a huge partner in the state. And part of that has been that the Thrifty White management in Minnesota has done a lot to really require their pharmacies in North Dakota to get on board. So I do want to acknowledge that there are strengths in more of the corporate entities.
I was kind of thinking,
some strengths. I say strengths and weaknesses. Sorry, Ramona.
I was kind of thinking as you indicated that they're, maybe more risk averse in terms of trying something new, but then also implementation and rollout could be easier once you get some big corporate chains involved. Another brief question, if it relates, I don't know that I have followed enough to say whether this question has been answered in the media, but some really big settlements happening with pharmacy companies. And I'm familiar with how tobacco dollars were used in various ways, sometimes not particularly around tobacco prevention or treatment. But are you aware of any provisions specifically that might, relate to the work that you're doing, or how are they going to use that money?
Yeah, great question, Ramona. So yes, recently the results of the opioid settlement, that is lawsuits by states against several pharmaceutical companies who misled particularly providers, regarding the addictive nature of opioids, which resulted in that increased volume of opioid dispensing in the 90s. So yes, those settlement dollars are now starting to come down, and that'll be pushed to the states, and then the states will allocate those dollars through the Department of Human Services. I think we do have the opportunity to learn from our experience with the tobacco settlement money, where in many states, less than 40% of the tobacco settlement dollars went to help the victims of the tobacco industry. And so I think there is an opportunity for us at the state level to be very vigilant to ensure that the vast majority of the settlement dollars go to help and protect the victims or the potential victims of the crisis. The temptation might be to use some of those dollars to patch holes in the budgets in different places. But I think we have a moral obligation to use the vast majority of those dollars to benefit the victims and the potential victims. Thanks for bringing that up, Ramona. It's going to, for those of you who are interested in this, stay tuned, because there'll be something in our local media or newspapers or whatever, at least weekly for the next year or so as this all comes down. And yeah, thanks. I think Rick might have his hand up. I was just noticing.
Yeah, thank you, Rick.
I just had a point of clarification. When you were showing the transition between the primary and secondary prevention, you listed symptoms there. In the past, I've experienced that transition is an indication of the onset of disease that's asymptomatic, and then the point of diagnosis is later on. And so the secondary prevention strategy is that point of screening where there is the onset of disease, but prior to any symptomatic detection. And later in the subsequent slides, it seemed like you were presenting it in that way. So I just wanted to clarify that transition.
Yeah, this is, and as you know too, you teach our MPH students, it drives them crazy because they want to have an absolute demarcation between primary and secondary prevention, right? And it's a little bit fuzzy, but thank you for the clarification.
Thank you, Rick. We do have a few more minutes, and I obviously am very interested in this topic. One question that I'm wondering, and won't take you too far down a rabbit hole, but do you know if they're changing the way that they're prescribing, say, for example, athlete injuries? It seems like just a particularly, really sad.
Yeah, certainly, back to my first slide, prevention activities are most effective when they're administered in places where you have known high prevalence. So I mentioned, pharmacies where patients are picking up their opioid prescriptions. But then prior to that would be a couple of locations, emergency departments, where prescriptions for opioids are written. Orthopedics, where procedures result in lots of opioid prescriptions. And then dental clinics. So yeah, good point. Those are 3 locations where lots of prescriptions are written, but they're, particularly with dentists and orthopedics, they're written for acute conditions, which there's plenty of evidence, by the way, and I didn't show any of that, but it's out. There's several really good papers, including one from Mayo, that demonstrate that for acute conditions, non-opioid analgesics are non-inferior to opioids. And so it was just I think a reckless practice previously that saw opioids as just being the par excellence, bar none. And that's just not the case. There's just as well pain management with most acute conditions using non-analgesic options. So it can avoid those 67% who are not chronic users. Many of those could potentially have been avoided. And frankly, many of them are. And that explains a reduction in opioid dispensing that I showed. But there's still room for more, because even having come down so far as we have, we still dispense twice the volume of opioids in the US as any other country.
Wow. And on that topic, I think I fall into the same category as Paul's wife, who's not enjoyed my experiences with opioids in the past, and have hopefully made choices to properly dispense of them. I have appreciated the med box myself and used it. But in my research methods class, I don't know if any of the students on right now are ones that chose to investigate opioid use in their analysis of national health interview survey data. But I know one student particularly looked at income and use of opioids, and I'm wondering if there's any established information out there about whether opioid use continues to be more prevalent with lower incomes versus higher incomes who can maybe afford chiropractors and yoga and yeah.
It's still the case that the lower socioeconomic status individuals are the ones who are receiving them the most and suffering the most. Yeah. I hadn't thought a lot about the fact that it's because of inability to afford, preferred non-opioid analgesic options, such as you mentioned. I haven't thought a lot about that, but that's an interesting, consideration.
Yeah, actually, I'd love to talk with you more. The data that I'll have to look and see which student it was, but it was very eye-opening. So a great secondary data set available to us as well. Thank you all for joining us.